Did you just switch it, Penny?
Did I switch?
Did you just?
Yes, we did. You're good
Okay.
to go.
Thank you, Ray.
You're welcome.
Roll call. Sorry.
No, that's okay. We are calling the meeting to order, and Penny is going to take the roll.
Dr. Smith?
I'm here.
Ms. Diaz?
Here.
Dr. Garza?
Here.
Dr. McBride?
Here.
Dr. Cunningham?
Here.
And then Bishop Hankerson. Don't think we have him. Okay, well, we have a quorum.
Okay. Good morning, everyone. We are going to start with approval of the January meeting minutes that Penny distributed earlier this week. I would move that we approve those meeting minutes. Is there a second?
Second.
Is there any discussion on the motion? All right, hearing none. Penny, do we need a roll? We need a roll call on the approval of meeting minutes, I think. Sorry, everyone.
I think we have, well, we haven't done it before, but we can.
Oh, no, then we don't need to do it now.
Okay.
All those in favor of approval, say aye.
Aye.
Aye. All those opposed, say no. All right, looks like we have unanimously approved the January meeting minutes. All right, a few things that we're going to go through today, and just visited with the new, what is Mr. Hayward's title? Director of Programs or Director of Education?
Community Corrections Manager.
Community, okay. And he is he oversees a lot of the different programs in the facility that.
Oversees pretrial and probation. So a lot of the pretrial activities are here inside while people are waiting trial. So programming, educational programming, and also the staff that supervise people out in the community as well.
Okay, so yeah, just had a chance to visit with him about some of the things he's doing, and he is going to come in next month to present more about the new barber training that they're doing here, and some other programs that he's excited about to help people, leave the jail and be successful. So that was good to hear from him. Why don't we start today by talking about long-term planning on the Mental Health Diversion Center. I know that you connected with a foundation representative in the region who's very interested kind of in this space of psychiatric care for people who are justice involved. Hopefully there's possibilities for some type of partnership with that foundation, because I know this is the kind of thing they want to support. Do you want to give us an update on the planning for that?
Yeah, definitely.
And we're talking about the Mental Health Diversion Center that that Scott had been talking about over the last 6 months or so.
So yesterday, I had an opportunity to present this proposal at the Crime Commission. That was the first meeting that Dr. Page had reinstituted for that Crime Commission. And I'll share some comments from that meeting as well as what our plans are. The Bear Foundation is a foundation that Jeff mentioned, and they have funded the mental health court here in St. Louis County for many years. And they're, as Jeff mentioned, they're interested in supporting more local efforts. Some of their funding support has gone to other states and communities like Boston, other places in Massachusetts.
And just for clarity, this is not Bear that took over Monsanto. This is like Bear, like Sticks Bear and Fuller, right, for those of us old enough to remember it.
Yeah. So in terms of long-term planning, I have a handout that we'll put in the minutes. There's a behavioral health crisis continuum of care that's been created by SAMHSA, and it starts with someone to contact. People can call when they're in crisis, someone to respond utilizing first responders and other people that can help with that versus making arrests, and then somewhere safe to go, which is what we've been talking about a diversion center. So in the county jail, 40% of the detainees are admitted with a mental health need. In Missouri, over 200 inmates are awaiting competency evaluation by Missouri Department of Mental Health. Our Justice Center currently has 41 residents awaiting mental health evaluation. Some of those detainees have been in the county jail for over 5 years as the court moves through a backlog of cases, and the Department of Mental Health deals with funding challenges. Right now, I'm told there's a $2 million request from the Department of Mental Health to fund additional beds and staff because of this backlog. So 1/5 of all of the people on that waiting list are here in St. Louis County. So we know the length of stay and isolation exacerbates mental health issues. And so some of the things that we've done to address mental health to this point are that the DPH and prosecutor's office have been major contributors to all of these efforts, and DPH coordinated behavioral mental health response, providing evaluations at intake and resource referrals, so that even if a person post bond and is released, they can have access to care that they need in the community. The Missouri Department of Mental Health dispatches a mobile unit periodically to our facility to provide care for the most chronic in need, including injectable medications that can be very expensive, and that's all at the expense of Department of Mental Health. We have registered all eligible residents for Medicaid so that when they're released, they can have quicker access to treatment and medication that they need. We've also expedited the process for identifying people in need of mental health services by initiating an appointment of counsel faster, because you can imagine if it takes over a year to get one of these evaluations, having an attorney that can help you file that process sooner can be important. Also, it allows us to identify people that might be eligible.
Can you just go into that? Just say one more thing about that. What is the typical length of time before counsel is appointed?
Well, so through our work with the MacArthur Foundation, I asked to look at number of people that didn't have counsel, and the number was too high. I think I recall that, well, I'll have to get the exact number. I don't want to misstate that, but we are shortening that length of stay, so I don't have the data in front of me, Jeff, right now to share it. So next meeting, though, I'll be happy to do that, and I'll try to get it. If we can get it and put it in the minutes, we can do it that way.
Should you do that, Penny?
Yes.
Thank you.
But the good news is that we've identified that as being a problem. First of all, some of the things we've done to address it are we put applications for public defender on their tablets, and that was done early on in October. But if you have a mental health issue, you may not be able to follow through on that process by yourself. So the steps that DPH has put in place and that we're working on now are helping make sure that they get an attorney appointed sooner. And I just saw that as a common theme in those weekly population reduction team meetings that we were having with MacArthur Foundation, that they would say that they didn't have counsel yet. So that's why I asked data to be pulled on that.
Yeah, for a while I know there was like a pretty acute shortage of like state funding for county public defenders.
Yeah.
But over the last like 2 years that finally got remedied, and so it shouldn't be a lengthy wait like it was years ago. But I'm just interested in the fact that you have to proactively apply for it. It would seem that if no one enters an appearance on your case, that there should be some like automatic process, you know, for a public defender to be appointed, because like, what if they didn't have tablets? I mean, they've only had tablets for a year.
Yeah.
So like, what was happening before that? You know what I mean? I just curious about what the mechanism.
Yeah, so we are looking at process improvement on a lot of different areas, not just this, but this is one that we definitely can improve on, and I don't doubt that it's better now than it was before, but I also think that the sooner we can do it, the better for people that need to get on the list.
Sure.
Yeah.
What's the length of time between when they come in and when they can access a tablet?
I don't know that answer.
It's usually, they're given a tablet in intake. So
Okay.
and they're automatically assigned a tablet upon intake. but, many times if we have shortages, they may get them a few weeks later. Just depends on when our shipment comes in with tablets.
Okay,
But they are usually guaranteed the tablets as soon as they come to the facility.
okay, thank you.
Okay, so we, also are recommending the development of a diversion center to help address trauma, administer medication, utilize community resources that can be provided better in our community. So I mentioned the meeting that Dr. Garza and Nina Riaz and I had with Michelle Schaefer, who's Regional Vice President of SSM Behavioral Health. And SSM has an urgent care center created to divert patients who require mental health care from emergency rooms. They have behavioral health care, urgent care at SSM Health is the region's first and only urgent care walk-in clinic dedicated to mental health. They treat adult and children with chronic needs. This provides immediate access to behavioral health care without having to wait for long periods of time and be a costly wait in emergency rooms. Another diversion center is being built at St. Louis University. These groups are interested in addressing mental health from a regional level, and the reason that I asked for this to be placed on the Crime Commission meeting is that because it involves many county departments, not just justice services. So in addition to prosecutors and public health, it also includes health and human services and the courts. This impacts us in many different ways. So we need to engage all the departments that are involved, as well as community leaders. And so this requires also funding. And so last week, Ruby Kazobash from Department of Justice toured our facility here to learn about our programs. I met her at the American Correctional Association conference, where we received the highest rating for accreditation of any jail. And she was so impressed with what we're doing. She toured the facility, and while she was here, mentioned that there's grant funding available for justice and mental health collaboration. So we're in the process right now of applying for that. Also, the MacArthur Foundation continues to provide grant support to reduce our jail population and have expressed an interest in supporting this. They funded diversion centers in Houston, Miami, and many other communities across the United States. So what I have on the handout also provides funding that's available through the National Association of Counties, and it's a compilation of funding that's available at different levels of government and through foundations. So we're looking at all of this now and plan to have many more conversations about how to address it. So the next step will be to tour this urgent care center that's at DePaul, and then from there begin to have additional conversations about some of the other funding opportunities that are in place. And obviously we're in a process of capturing more data and better data on mental health, so Liz may be able to speak more about that.
Hi.
Hi.
I don't know what else you're...
Well, they're looking now at the online data records and how we can track mental health.
Through our electronic health record, yes, we're hoping to expand our electronic health record to be able to capture additional statistical data that we're wanting, but we're needing a new electronic record. So we're working towards that to be able to capture.
Okay, I have a couple questions, but I want to let Nina and Alex, since you guys were part of the meeting that Scott referenced, I'd love to get your takes, and then see if other board members have feedback, and then I have a couple questions.
Nina, you want to go ahead?
Sure. Well, we had a great meeting, and it seems like there are steps being taken that will get this the data captured, and also the diversion center learning a lot from what SSM has already accomplished. And so I'm going to be joining that tour, and I definitely look forward to that. Alex?
Yeah, just to reiterate what Nina said, I thought in what Scott laid out there. I thought it was a really good meeting. Michelle Safer and her team with the behavioral health component of SSM has really put together a nice urgent care clinic and long-acting injectable clinic that serves a highly vulnerable population. And so just from a high level, it seems like there could be some synergies here, but just to level set as well, though, there's not like there's an endless supply of mental health providers, and so it has to be correctly built and fashioned and implemented to be successful. But I'm very encouraged.
I guess I want to jump in. With that tour, DePaul, I would like to attend that as well. I think there's a significant overlap between corrections medicine and what we're trying to work on as well with mental health and substance use. So I'm wondering if there's a way that we're able to collaborate with them internally. I know we're working on our team working efforts, but then also with DePaul. And if there's other facilities as well, like you said, SLU is coming up. But I would like to attend on behalf of DPH to be included in that and make sure that information is being translated to the corrections medicine team and how we can develop a support system all the way around. But I think that's great what you're doing. I think it's amazing.
Yeah, fantastic. We definitely try to coordinate all the schedules and get something set up for March.
Okay.
Tim, I saw your hand tentatively going up.
Yeah, just real quick, and I think this all sounds really positive, and and I'm very encouraged. In terms of data, you may have this data, or I'm just going to encourage maybe compiling it. Just a hypothesis I would have is people with these challenges coming into the jail, I wonder if they're heavily correlated with the ones who might create some of the problems we have in the jail with incidents. So if that could be looked at, that some of the violence and other incidents. So, because that might make the case for how this could be cost effective as we deal with this issue at the front end, or along the way, you might actually reduce some of the incidents that we've been talking about. That's just a hypothesis I have, but I don't know if I'm right.
Tim, we could look at that. It might take a little time because that's not exactly the kind of thing that we could just pull from IJMS right away. It'd probably be a manual, correlation. But yeah, I mean, I've already heard several good ideas on other data we could pull. So if with respect to any of these mental health data pulls, if you all want to kind of summarize a list of things that we can look into before the next board meeting and send it to me and Scott, and then we can discuss which ones maybe we can go after in the next month.
I'm great at creating work, so shut me down if you want to prioritize.
Okay.
Thanks.
Yep.
I also plan to have some discussion, and hopefully this will be something that's coming from all of us, not just Justice Services, but there are 13 states that have implemented virtual competency evaluations during the pandemic, and I think it's clearly something that if we can communicate and work with State Department of Mental Health, that this could be a win for all of us as well.
So my main question is, and everybody else on the board has, I think, kind of like some expertise in this area except me. So this is probably a really dumb question, but the SLU, if SLU's got something that's in the works, is there any possibility to do something collaboratively with them, or would the populations that they would be planning to serve be too different from a justice-involved population? Although, we're potentially talking about diverting people from justice involvement here due to a psychiatric, evaluation. So I'm just wondering, is it possible if they're, given SLU's resources and what we could potentially bring to the table, to do something collaboratively?
Definitely, yeah. I think that it requires a lot more conversation and meetings. We've had 2 meetings so far, so we're at the very beginning stages of this.
Yeah.
But I do think that, and there are other facilities like a diversion center for opiates that has been funded with some grants in the city of St. Louis, and I think it's entirely possible that we could have an 800 number for people to call like they do in the city now, and that this could be set up with ride-alongs with the police department, but those all involve other departments. So that's why we initially rolled this out at the Crime Commission meeting, and we'll just have to have a lot more follow-up. So we go out and see the facility at DePaul, and there's interest there in looking at how that could be expanded. Then that could lead to conversations with the new site in St. Louis. But at the very least, we can learn from how they've established that. If you look at the population, though, Jeff, it is the population. 1 in 15 adults are in prison, 1 in 3 African-American men, 1 in 32 adults are on probation right now or parole. So it is the public.
So
I will say this. Oh, sorry, Jeff. Sorry. Go ahead.
No, go ahead.
No, I was just going to echo what Scott was saying, just so you all would know. So as far as with DPH, this would be something new for the county, but I am interested in trying to develop a similar program like the city, the cops and clinicians. But I have to see how that will work out and get additional partners or either like alternative crisis response teams. And so there was an article that I read recently in our American Journal of Public Health that spoke to the need of, public safety is public health. And how that would look with diversion programs. And so I did express an interest with my team to kind of do a little digging around and see what capacity is at DPH or even a community capacity to develop something of that sort. Similar to cops and clinicians, I think in what you're saying too, Scott, would having ride-alongs or, triaging at the call center, the 911 call center. So there's different models that currently exist that are successful. But I am interested, at least on DPH side, to kind of do some initial research and see if this is something that's possible and what would be the role that DPH would play with this, with, mental health diversion and partnering with other departments. So I'm glad you're working on that. I think it's the way that we need to go because currently what we're doing just all throughout our departments, it's unfortunate that our community is still being harmed, and a lot of us can recognize that it's either mental health or either substance use or we know that it intertwines with crime, but I have a significant interest to, try to jump in and help from a public health perspective.
And I do think we'll have more time at future Crime Commission meetings to have more discussion.
Yeah.
So
I plan to put something together and present it to Dr. Page and see what he says.
Excellent.
And so you're talking about you want to put something together like kind of collaboratively and approach Dr. Page with it?
All of this would be collaboratively. If you look at diversion, that really starts with the prosecutor's office.
Yeah.
And they do have some mental health diversion. Wesley Bell has expressed strong support for this, has a staff person on the committee, Danielle Smith, that's working with this. And clearly, Department of Public Health needs to be a major player in this. They're already doing some things as well. And then we look, the police department would be involved for ride-alongs. And we have, if you look at services that are already being provided to people out in the community, Health and Human Services would be involved. So the good news is we're all interested in working together.
Right.
And we're at a starting point, and we have support here from this board and a lot of expertise that helps us. We would never have had a call, I'm confident, with the Vice President at SSM, but for our support that we have here from Dr. Garza. So thank you.
Okay, so sounds like everyone is pretty much on the same page in terms of wanting to do this, and you're exploring all different kinds of options, ranging from some kind of maybe collaborative with SLU or with a local hospital network or a standalone county facility, all those options would be on the table.
Yes.
Yeah.
Definitely. Okay.
And if you look at these diversion centers, we likely will tour one in Houston. MacArthur Foundation is looking at supporting that to be able to visit. So we're just in the early planning stages of that also. But some of them have psychiatrists on staff that can prescribe medication. They have beds, like in Houston and Miami. Others are in rural areas, like in South Dakota, where they just serve as like a 211 site to refer people out to community resources. So there's a big range of what this could be.
Seems like we would need one with beds.
Well, obviously getting to that point, it helps us because people can get better care in the community than they can here, especially if they're here for long periods of time. And while they're waiting for trial, they could be somewhere in the community getting care versus the jail.
So Jeff, I'll just make a final comment if that's okay. So, and that's just, these are all great ideas, lots of potential that are out there, but I'm always reminded of General Bradley, who says, novices talk strategy and professionals talk logistics. So we always have to be aware of the reason why we're in a mental health crisis to begin with is because of that severe shortage of mental health providers. Well, there's lots of reasons, but that's one of them. And so I just want us to be clear-eyed about how fast and how far we can move at any given time. And so I think if we can start out with something that's reasonable, like what Scott is talking about, and then we can carefully articulate a strategy on how to expand services or do other things. So I just want us to be very realistic about how far and fast you can move given the environment that we have. And I see Tim shaking his head, and it always makes me feel better when the economist in the room is shaking their head yes.
Thank you, Dr. Garza, because you're right. Yeah, we need a lot of ideas, but you're right, realistically, and what we can do. And I appreciate that. It is absolutely right.
Yeah.
Yeah, and so we're really talking about 40 people that are waiting beds and or evaluations as being the most chronic. But if it's 40% of the jail population, that means there's 450 people that have mental health needs. So I read an article this morning that the Bureau of Prisons is partnering with WellPath to have virtual counseling for people in their residential reentry centers. That's just being established now, but it's something innovative that never would have been done in the past. So they're opening up the possibility of using technology to be able to provide things, and I'm sure that's a result of the pandemic. Mm-hmm. So while it was a challenging time, it also has put us light years ahead of where we would have been otherwise.
Yep, absolutely.
Okay, thanks for the reality check, Alex. Yeah, I mean, psychiatrists are not growing on trees, and and certainly, as hard as it is, I think in all these professions that we talk about, when we have shortages here at the jail, it's like hard, there's a broader nursing shortage. The shortage of nurses ready to work in a correctional facility is always more acute than the broader one. So definitely mindful of the challenges. Thanks, everybody, and we'll look forward to hearing more from you on that, Scott. On a less sanguine note, let's move to the next agenda item, which is a follow-up on the November attack on the officer. So just to recapitulate, we know that, and I don't remember the month that you had issued a directive to I don't know if the directive was a all-staff email or to your senior leadership team, directing unit managers to ensure that pods were always covered by 2 people. And then we know that that wasn't the case in November when the officer was attacked. And so we asked, we know there is an investigation that's ongoing around that, that has, I think, is even more broad than that around just adherence to policies and procedures here at the facility. And I think I said last month at the meeting that this was going to be an agenda item, you know, every month until we understand more about what's happening with both that broader investigation around adherence to policies and procedures, and then specifically what led to the lack of adherence on the day when the CO was attacked in November. So I'm wondering if you have any updates that you can share with us today.
So I would love to be able to do that, and unfortunately I can't talk about that. But I can share what we're continuing to do.
Can you talk about what's changed since then?
Yes.
And then, you know, and if there have been, I understand that because it's a personnel issue, you can't name names, but are you able to tell us if there has been any action, both on a policy level or a disciplinary level, in the wake of what happened?
Well, we have changed our scheduling process, and we are looking at all options. I think if and I may have mentioned this at the last meeting, I immediately put a process in place so that watch commanders would write the names of the 2 officers that they saw during their tours. Because I was in here on weekends, holidays, all shifts, and was seeing 2 people. Now that process has been followed. Each day I look to see who the names of the officers were. It provides us with a record of, if we find out down the road that there wasn't, then we can go back and look and see who was supposed to be in those housing units together. And, you know, we are continuing to struggle with just staffing in general. But this is a priority for me personally, and it's something that I implemented following the assaults in November of 2021, and it's now been 3 months since that last assault, and I'm hoping that we do have some resolution to this.
Do you have any sense of a timetable?
I do not. Yeah.
Okay. Are there any questions from the board on this? Tim?
So if I hear you right, Scott, and I appreciate that, and I know you can't talk about the particulars of this case, I think our board, you know, is probably can probe more about policy. So I appreciate your update on that. What I'm hearing is that there may still be some concerns about staffing to make sure that there's always 2 people in a pod. Is that what I'm hearing?
Well, we'll get into this a little bit more when we talk about staffing and recruiting, I think, rather than jump ahead. So if I could hold that until that, and I think it'll be pretty clear about where we're at and what I'm referencing there.
Okay.
It has nothing to do with what happened in November and more to do with the future. And so we'll cover that here just in a few minutes.
Okay, so it's still your policy to try to enforce the 2 officers in a pod, though, right?
It's always been my policy since I sent that out over a year and 3 months ago, and people did not abide by the policy. And
right. Got it.
And so, and so part of what we want to get to is, you know, why were people not abiding by the policy? Is this a systemic issue that other policies have been also ignored or systematically not adhered to? So I think those are some questions we have. I know those are some questions that are being examined as part of the broader investigation, and we would look forward to hearing because I'll put this on the agenda next month as well, what has been learned in the investigation and what's being done to address whatever is learned. Okay, why don't we, I'm just gonna segue and skip the staffing update up to now, okay, since we're talking about that. And I know in a recent conversation with Dr. Page, he was optimistic about not letting the $3 an hour raise, not backsliding on that, because I know that was in jeopardy for a while. Can you give us an update on that, on staffing in general, but in particular on that, which I know you were very worried about?
Well, President Biden has said that the emergency declaration is ending May 11th, and as a result, the premium pay for people that were working during the pandemic is ending. And in our case, that was $3 an hour for people that, many people in the jail. And so we had an item on the civil service agenda. That meeting is rescheduled due to some technical difficulties, but I'm hopeful that we'll be able to make that $3 permanent for corrections officers with our existing budget. And then we'll be making a request to the council for additional funding to be able to, because we don't have that in our budget. And you may recall we discussed at a previous meeting about 75% of vacancies being cut. That equates to 54 officers for us. So we're at a point now where we have filled all of the other vacancies that we have, except for those additional 16, which we were fortunate to get approved for this year. So we'll be making a request to the council again to approve funding for some of those positions that were unfunded, with the goal of being able to continue to increase staff. So the good news is that we are continuing to bring on additional staff, and we still have a big need, and having 2 officers in the pod does require more staff than 1 officer, as you can imagine. So we have potential of renewing a federal contract, which would bring in several $1 million that could help fund these pay increases permanently, and have also done some other things to generate revenue. The municipal contracts have been renegotiated. We have
at higher rates.
Yes, we've found areas where we can bill the state for holding probation and parole violators, which has not been done in the past, which will provide an additional $2 million. And so we do have ways of funding it. It just requires council approval to make that permanent.
Okay.
So if you know, so that's how I reference this, is we have to have the staff to be able to maintain 2 in a pod. Right now we're doing that, and hopefully we'll be able to continue to do that in the future.
All right, are there any questions from the board? Okay, appreciate you guys, the ingenuity on the funding side to, find places where we had not, where the jail had not maximized revenue to date. Okay, let's move on. We had a visit from some national folks last week that I heard went well, from the Bureau of Justice Assistance. Can you tell us about that?
Yeah, so mentioned briefly about Ruby Kazabash, who toured. She is the Deputy Director of Bureau of Justice Assistance, and that's a division of Department of Justice, and they are the branch that provides all of the funding to counties, to jails, to prisons, to county, state government agencies. And so right now there are about $86 million in grant funding available. One of the grants funds education programs. So we're looking at getting applications in further expand our educational programs that we have at the jail. Another provides vocational training programs and Second Chance Act employment opportunities. So I mentioned mental health. There are many grants that are available now through that agency. And they were here actually, along with others at Department of Justice, to roll out some community grants to address community violence. It was a community violence initiative, and Dr. Page spoke there, I understand, as well as Amy Solomon, a good friend of mine who's Deputy Director of Department of Justice, Attorney General's office.
So like cure violence, or what kind of community violence programs?
Yes, so they rolled out a series of community grants to local communities, and all of the grantees were here in St. Louis to have their initial presentation about the support they would be receiving, and that was here right here in St. Louis.
Good. Questions about, and so was there any concrete takeaways from the visit, like a particular grant that, you know, or a particular program that they're interested maybe in funding that?
She spent 4 hours, almost 4 hours here, and the great thing was that we also had people here from MacArthur Foundation because they have the racial equity grant, and we're here to discuss that. So we sat in this very room afterward and had a time to talk about how the foundation and BJA could all work together to support what we're doing here in St. Louis County. So the primary interest with her coming was the college programming that we have. That's typically done in state prisons.
Yeah.
So to be able to do something like that in a county jail is really a model for the rest of the country. And so I think,
and we'll hear more about that next month when Mr. Hayward comes in.
That's right. Yes. So I think that's the primary, but also spent a lot of time talking about the mental health diversion center, and that funding is typically, if you look it up, you'll see that it says that priority is given to rural communities, but I believe that we'll have a real shot at that as well if we get the application in.
All right. Any questions about that? Okay. Why don't we move on to a voting update? We have, is that?
I'm not sure that was supposed to go on there.
Okay.
Have a voting update? I may have.
Well, I know municipal, you know, with municipal elections coming up, I'd be curious, are we just doing, I actually talked to, I was on the way home from Jeff City, and I was in Wentzville, and bumped into the St. Louis County elections director, who out of nowhere just walked up to me and said, I love it, you know, it was one of the most satisfying professional experiences he had had, was coming in here and helping administer the voting. He said, and I'm paraphrasing here, something to the effect of, yeah, in the past, they had maybe asked us to mail in some forms or some ballots. This is the first time we've ever, like, actually come in and given talks to people about, you know, how to vote, the importance of civic participation. He said it was actually not only very rewarding, but he thought really well received by people here to feel like they were, you know, not being shunned, but still a part of the community. And of course, they're pre-conviction, and so there's nothing in statute that would prohibit them from voting. Anyway, is there anything in the works for the municipal elections this spring?
Well, I appreciate you bringing it to my attention.
Yeah.
And I definitely agree with what you shared about that entire process, and I was told that it's actually more efficient for everyone to do that here in person rather than to have mail-in ballots.
Okay.
And the response is much better. So we're continuing to do the education of people on voting, and with a plan to continue to do that. So I have not considered municipal elections, so I need to look at it more and see how that might work here.
Okay.
Yeah.
And, you know, turnout's always much lower in municipal elections than, you know, than fall general elections, and so you probably won't have the same type of rate of participation just because they're, you know, lower interest elections, but, yeah, just putting it on your radar screen and keep us posted on that. All right. Not seeing any hands raised or hearing anything else from the board, why don't we move to the dashboard? Aaron, take it away.
Okay. So I wanted to mention several things this month. So in January, we talked about this at the board meeting last month, but we had a big increase in the population in January, as you can see here. But in February, this has pretty much leveled out. We've been pretty much even. We're at 879 as of today. We were at 864 at the end of last month. So for the most part, this increase has been stabilized, which is a good thing. This was largely a result of, if you look at the bookings, you'll see that there were almost 1,100 bookings in January, which is much higher than there were in the prior months. There was a difference when there were almost 1,100 bookings and there were only 1,000 releases. So that really makes for the difference of why the population went up in January. I did a quick look just earlier this morning, and we are on pace for over 1,000 bookings in February as of today, but the gap between bookings and releases isn't so high. So that's what's, you know, allowed the population increase to stabilize, which is good. We're hoping we can get it down again, but it seems as though the rapid increase that we saw in January has pretty much plateaued, which is a good thing.
Hey, Aaron, before you
Yes.
move on from that, just looking at your graph there on the upper left hand, it looks like there's always a sharp increase going from December to January. Did you see that when you trended this up?
Let's see. So here's January here. So I
Okay.
could go back and look at 2020. For
Yeah.
2022, it looks like there, from 2021 to 22, it doesn't look like there was. I see 827 and then 797. But it looks like last year the big increase was from February to March.
Okay.
So I'm not sure if that's specific to December to January. However, I will say that we did see during the board meeting last month, we looked at some ups and downs in the population and did notice that it might not be that the bookings go up a lot in January every year, but it does seem like the biggest gap between bookings and releases does seem to happen in January's, because we saw 3 years in a row where there was some kind of V shape at the end of the year, and then the, you know, end of the year down and beginning of the year up. We saw, it's not displayed here for 2020 because I shifted the dashboard window, but we did see.
Do you think that's
21, 22, and 23, we saw some variation on this V shape. Yes?
I was just wondering, do you think it's because, like, court basically stops in the second half of December?
Yeah, that was one of the hypotheses. Another hypothesis was about the coldest month of the year, but I'm not sure if I really am as into that hypothesis because, you know, November, December, February, you know, January, February all have cold spells. So I would, if I had to guess, I would put my bet on it being related to the courts.
Okay. Observation. Thanks, Aaron.
Kind of hard to do like a fully descriptive analysis of that because, you know, linking court data to the population data is kind of precarious, but I think that's probably the best hypothesis we have. Yeah. As for average length of stay, we were pretty steady this past month at 69 days overall. that's pretty middle of the road for the past 2 years. Use of force was down substantially in January as compared to the prior months, which is good. We're at under 20 per 1,000 residents, which is a good thing. The other thing that I wanted to mention, excuse me, I'm sorry. I need to pull up the regular supplemental dashboard. There we go. The other thing that I wanted to mention was these two bottom right windows here. And the reason I wanted to mention it is because oftentimes when you see the resident to corrections officer ratio change and the open DJS positions change, the underlying cause is one and the same. But the increases in these two, the reasons behind these two increases here are actually two very different things. So you'll see on the open DJS positions, we went up from 57 CO openings at the beginning of January to 78 CO openings at the beginning of February. This was largely because there were more CO positions allotted. But the resident to corrections officer ratio takes into account only the number of COs we have, not the number of total CO positions theoretically. So the reason this went up didn't have anything to do with the increase in open positions, but rather the increase in the overall daily population that happened over the course of January, if that makes sense. So these two increases both occurred throughout the month of January, but they're actually relatively unrelated to one another.
Aaron, you hit on the graphs that I had been wanting to get asked questions about, so I appreciate it. But
sure.
The one that also I'm kind of wondering about is the age by race, gender.
Yeah.
And the white female has taken a big jump.
I know, it's been going up for a while. It's gone up. White females have gone up in age by an average of about 8 years over the course of the last year and a half.
Do you have any idea why that is?
I could look into it more. I have some hypotheses, but they're purely speculative. I do know that, like, in general, the white population, is aging. I mean, the population's aging in general, but I think the white population is aging at a faster rate than the black population, if I recall correctly. But I also wonder, since so much of it, like, occurred in this, like, couple months here, if, like, trying to think, if we saw people, like a disproportionate number of the people who were released in that 2 or 3 month span be like younger people who had been in the jail for a long time, and the older people, white females who had been in the jail for a long time, have remained. That's my other hypothesis. But it would be interesting to see why, because that's like demographic trends don't usually move that quickly.
No, yeah.
I will also mention, though, I will say this. White female is a pretty small group when it comes to looking at a snapshot in the jail at any one given time. So this, I should clarify, the monthly average resident age by race and gender is based on looking at, basically the way that metric is calculated is by looking at daily snapshots throughout the month and then averaging those snapshot numbers together. But it isn't the same as looking at the average age of all white females booked throughout the month. Right? Because there are plenty of white females booked throughout the month, or presumably probably younger, but they're just, booked and released within a day. The reason that I do it this way is to try to emphasize the people who are actually like chronic residents of the jail and tease out the noise from all the people who just run in and out, in 4 hours or 6 hours or 12 hours. So, if I were to calculate this metric by taking all the people booked in the jail, whether they were admitted or not, and averaging out their age, that might be different than taking 30 daily snapshots throughout the month and averaging out the results from those. Does that make sense?
Yeah, it does. It
Yeah.
may be, in other words, it's possible it's just noise.
I mean, it's
Yeah.
by noise, I think specifically you would mean the difference between the way that the composition of the people who are in jail for long periods of time versus the age composition of people who are just booked and released.
And small sample size. I was just trying to see if there was something.
And there aren't a lot of white females who
Yeah.
are in the jail at any one given time. I mean, I think
Yeah.
the jail is 85 to 90% male at any one given time. So right there, that's already, under 100.
Yeah. Okay. I just wanted to make sure there wasn't something changing in our society that might be leading to this, like SEDs or something.
I don't know. We'll see how it goes over the next year. I mean, most of this increase has taken place. Basically, this number started running away from all the others at the beginning of 2022. So it's been one year. So we'll see what happens over the next year, and we'll see if that number comes back to the rest. But it is, I will mention this, it is always the case that the average age of the white residents in the jail is substantially higher than the average age of the black residents. That is pretty much always true.
Got it.
Yeah.
Thanks.
Sure. So did anybody, I know, Tim, you had wanted to ask questions pertaining to these two graphs. So if anybody else has questions, please feel free.
The whole country is fixated on crime among young black males, but in St. Louis County, the problem appears to be the Karens, Tim, huh?
No comment.
Okay.
To be fair, this doesn't say anything about how frequent these categories are, just the average age.
You're not going to get me to comment on that one, Jeff, in public.
Okay, Aaron, do you have anything else to add on this?
I don't think I have anything else from the dashboards. I will reach out. I'll reach out to the board, and I'll copy Scott on the email as well, sometime in the next week or so, to discuss possibilities about mental health data. Our hands might be a little bit tied, but I at least want to explore some data possibilities.
Just something to clarify on these graphs for staff. There were 16 new additional positions allocated in the budget, but that chart also still includes the 54 unfunded vacancies. So that's why that number seems a little higher.
Right. So this graph here, almost the entire explanation for the increase can be explained by the fact that we were allotted new positions. So this increase isn't really much to worry about because the green bar just went up from January to February because we experienced new positions. I will say, I think the number of old positions that are open did increase by just a couple, but a vast majority of this increase is just the fact that we were allotted new positions. This increase in the resident to corrections officer ratio is unrelated for the most part to this. In this case up here, the reason it went up is because the numerator went up so substantially in January, the number of residents. So
right.
Usually these two metrics are correlated with one another for one reason, but in this case, they went up simultaneously, basically for two unrelated reasons.
Right.
So that's all from me. If nobody else has any other questions, I can pass it on to Liz now.
I can also add a little bit about why the population increased. There were
Sure.
5,000 municipal warrants that had been not active that were issued, and that has resulted in a big increase of people coming into the jail. Majority of them post bond though and are released, but that is why the number of bookings and initial count is increasing so much. We had an increase of 100 just in the past month, so hopefully we'll see that go back down.
And we have seen it level off in February for the most part. Fortunately, we have not seen that keep going up.
That probably explains most of that increase, Scott. How come they had all those bookings backed up, or bonds or whatever?
Those primarily, many were failure to appear that had not been activated during the pandemic. A lot of reasons behind that, but those were all entered into active, the mule system by the municipal courts. And so,
okay.
I can speak on this a little more too. It's a mix of the municipal issue, and we're also just seeing more low-level offenses come in. I think, if I remember right, we're up about something like 40 or 50 low felonies C level or lower over the past like 3 or 4 months. So that makes up probably 40% of the change too.
we have opened up another housing unit as a result of it, which takes additional staff, so all of this impacts that.
Okay, Liz, the Corrections Medicine Dashboard.
Okay. I would like to say that our mental health team that we added, our psychiatrist and psychiatric nurse practitioner, since our former psychiatrist had left us back in November, we're up to date with all of our mental health visits. So with the psychiatrist and the nurse practitioner, we have seen pretty much all of our patients that have been waiting to be seen, that they're on a regular schedule to be seen and taking care of their mental health needs. So we're very happy with the fact that we are really able to stay on top of mental health requests in order to be seen by a provider. There really isn't any as far as our transfers out to the medical facilities has decreased. As far as people having to be hospitalized for medical care has come down for the month of January. We continue to request, as far as substance abuse, getting individuals to consent to the urine screen so we can detect what a person may have at intake. That always is a challenge on a daily basis to get individuals to consent, but we're maintaining as far as cooperation. That hasn't gone down. We would like to see it, of course, go up, but every day is a different individual. Some individuals will consent and others won't.
This might be a really dumb question. What's that conversation look like? And is, you know what I mean? Because I mean, I would assume, you know, they're thinking, you know, if this is dirty in this way, will lead to more charges. And
yes.
You're thinking, we want to make sure that if you're withdrawing, we can provide you the care that you need.
Correct. And we've added some signage at intake, meaning that our request is purely for medical reasons only, so that we can better treat you. It's in our best interest. Sometimes if an officer's not there, sometimes officers can actually say it's really in your best interest to do it, and they will cooperate. Other times, if an officer steps away and medical can say, really, this is what we're using it for.
That was what I was gonna suggest.
But I've received reports from the medical staff that said that on some occasions, that an officer can actually, talk to them and actually say, this is a part of the process, it's for your best interest, medical needs to know, and it works. So it just depends on the person, what's going on with them.
So is there, you can tell them, honestly, that result will never be communicated to the prosecutor's office, right?
No.
No.
I mean, because they can subpoena records. We're saying that we are requesting a sample so that we can treat you medically.
Okay.
Because everything goes into the electronic health record.
Okay.
And so what a prosecutor may or may not do, that's something
Yeah.
But, so we're not saying that. All we're saying is that we need your cooperation so that we can better serve you. And that's throughout the whole facility. That's if you are withdrawing, we have medications to help you. We don't want anybody to suffer. We're here to provide services. And that's even upstairs. Once they move to general housing, if they've got other things, we're always saying, we can help you. And please, cooperate. We can get you taken care of. So I know that mental health is big, along with the substance use. We try and stay diligent to be able to provide those services to our population and take care of them the best we can. So we're really pleased with our in-person, Dr. Junaid and Jessica Booker, who are our newest members to our psychiatric team. We've added Courtney, who is a licensed clinical social worker, who will be doing groups up on the pods to be able to help with mental health issues and concerns that individuals may have in the jail. So we're really pleased to be able to start the groups. Just to overall, we're adding to our team and provide more coverage and services.
That's good.
So.
Questions from the board on anything that is on the medicine dashboard?
I mean, the next page is just individual illnesses that, of course, truly maintained. Sometimes we go up and down as far as hypertension and other medical conditions of our population, but there's anything really truly alarming that I needed to bring to your attention.
Could I have you go back to the other medical dashboard for a second? And I don't know if I want to say this is alarming, or I just wanted to focus in on it. The substance use disorder one. Thank you for blowing that up. In the last 7 months, it's grown quite a bit. But on the other hand, in May and June, it was bigger. So how do I interpret that or understand that? Do I worry about the big increase or the slow, steady increase in the last 7 months, or do I not get too worried because it's kind of a roller coaster?
Well, with the increase, I would have to say that would also correlate with the increases with admissions to the jail. So if we've increased the actual numbers coming through, then of course we would potentially get raised numbers of substance use. I cannot say anything as far as it's a reflection of what our society is experiencing and we're trying to deal with here. I don't know what happened as far as the admissions in May and June as to why we admitted so many individuals.
Yeah,
Tim,
it may be a reflection as well. Yeah, it may be a reflection as well as how many people are willing to
submit.
participate in the testing. So, as we the classic example that I taught in epidemiology class where we saw a dramatic increase in HIV positive patients, but that was because we'd had better testing. It wasn't because, there were that many more HIV patients out there. And so this may be a reflection of that too. But related to what you just said, are there any best practices from around the country on addressing substance abuse testing within the incarcerated population as far as the approach? So you mentioned sometimes medical personnel if the guard isn't there, sometimes if the guard is there. Are there any lessons that we could incorporate into our services that you've seen in the literature?
It's developing the relationships that is what we've heard. Dr. Davis has a network of medical directors so that we can inquire as far as the actual approach from other facilities. Do they have 100% of cooperation, or what is their percentage of cooperation and intake? And we can inquire on that. Dr. Davis has always wanted signage so that because, it's always traumatic coming in intake.
Yeah.
And so sometimes they don't necessarily comprehend what you have said, but if they can get a minute and actually read something potentially on the wall, they may be able to understand exactly what's going on. People, just depends on how they're doing at that particular intake is very traumatizing for individuals coming through.
Right.
I reviewed everything. We do need to revisit best practices just all throughout with our MAT program. So there's a lot that we need to do. And like I said, this was established back in 2018. They brought Rhode Island, and Rhode Island is still a model around the country, but the previous directors brought in Rhode Island Correctional Facility specifically to assist with St. Louis County developing our MAT at our jail. But I agree that I think we need to go back and revisit best practices, evidence-based practices. In 2023, what was done in 2018 is not the same as what's being done now across the country. So, Dr. Garza, I thank you and I appreciate you bringing that up, and that is something that we need to revisit.
Thank you so much. Thank you, Dr. Cunningham, and thank you.
Welcome.
Thank you, Dr. Cunningham. Yeah, I've read a really good article about Rhode Island and what they were doing like a year ago, and I think in Politico as like a best practice, and I think Maine was doing something similar. So if I'll maybe send you and Liz a couple pieces that I've read on the topic and see if it's illuminating it all. But yeah, that's interesting information that I didn't know about the approach that you guys take in intake to try to put people at ease. So thank you. All right. Anything else on the medicine dashboard?
I think the other thing to add, I was notified that we have included Sublocade on our formulary. So I think that is amazing. And Dr. Davis shared that they have done 3 injections with Sublocade. So I think that's amazing that we are able to include that on our formulary and have that available option when we, think about treatment. So I'm excited about that, and that's something that's new.
All right, Sublocade is a long-acting injection to treat opioid use. So that's what we've done. So they'll do it every 28 days.
Is it like Suboxone?
Yes.
Yep, it is.
Long-acting.
Yeah, it's better.
I just had never heard.
Yeah, it's newer. I started using a lot of it in clinical practice, but what it does, it actually right now, given the nursing issue and staffing shortages, but it allows us 1 injection every like 28 to 30 days. So it's definitely a fan of buprenorphine compared to Vivitrol, and I think this is something to help increase our treatment numbers additionally in the jail as well.
It's what compared to Vivitrol?
It's better than Vivitrol. I have issues with
it's more effective. Okay. Because of higher efficacy or lower, like, not as serious side effects, or what?
No, so Vivitrol is an antagonist. So buprenorphine, if we look at the molecular level, we're thinking about the receptors and how opioids work. Buprenorphine attached to those receptors a lot better, help minimize and prevent withdrawal. With Vivitrol, some of the issues with implementing that, like someone have to be opioid free for 7 days. And so with that stated, either someone have to be given comfort medications before they can start Vivitrol. Now, it is a great medicine, I will say that, but sometimes people, there's bias and stigma behind choosing Vivitrol compared to Sublocade. And now since we have Sublocade, and we do know from studies that buprenorphine is slightly better than using an antagonist. So that's why I'm excited about it, because it works better to control cravings and withdrawal symptoms. Vivitrol is likely really well for controlling cravings only, but Sublocade can help treat both. And so that's why I think it's a better agent. I think all of them are great, but if I had to pick between Vivitrol or Sublocade, I'll definitely pick Sublocade.
Okay, thank you. That's super informative. What's the reason for the stigma?
So when treatment came out, people, Vivitrol is an antagonist. So people think that buprenorphine is, they relate it to as a medication that's enabling because it's a opioid as well, with understanding the mechanism behind why buprenorphine is a successful medication. So people think of Vivitrol as, oh, it's not an opioid, you're not enabling. So a lot of press around, well, we need to give people Vivitrol. But what people fail to know about Vivitrol is if someone is stabilized on it, which is really great, but if someone have a recurrence of use, they actually can increase their risk of an overdose based on the simple fact of how Vivitrol works. So that's why I have issues with when people push Vivitrol, that risk for me that if someone returned to society or have a recurrence of use, that risk of overdose to me is just too great of a risk that I wouldn't want to take. And you don't see that with buprenorphine. It's actually protective against an overdose, actually.
That all makes sense. And so the higher stigma of the Suboxone, or what is it, Sublocade? Right, but so the higher stigma is attached to which one?
Vivitrol.
Vivitrol. Okay.
Yeah, I think I'm hearing your question right. There are certain people, I'd say professionally in a professional community, who will push Vivitrol because it's a like I said, an antagonist. It's not considered an opioid-like derivative or opioid-like. So that's where it comes in if people want to push for Vivitrol.
Okay, that makes sense. Okay, thank you for illuminating that. All right. Anything else on the medicine dashboard?
I just want to thank Dr. Cunningham for that thorough response.
Thank you. I love talking about this. So I can talk all day about opioid and treatment, stigma, and the historical impacts. This is I love talking about it. So thank you.
Good. All right, Penny, is there any public comment?
There were no public comments.
No public comments. Okay, well, our next board meeting will be March 24th. I guess February is 28 days, so we get exactly on the same day next month. So we will see you all on March 24th. We will have a presentation from Community Corrections to hear kind of in more detail about some of the programs that you talked about. And you also told me that we are planning to do voting for the municipal election. And another big ancillary benefit is that employees who would have a tough time getting to vote if they're in here all day also can vote in the same, through that same process. So great win-win to help them vote at the same time. Okay, everybody have a great weekend. Thank you all. And we will have, I think, a new board member for our next meeting, and I think we may learn more about that today if you follow county news.
Yeah. Do we need a vote to go out?
Oh, thank you. So can I have a vote? I move that we adjourn. Is there a second? Tim seconds the motion. All those in favor, say aye.
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 All those opposed, say no. The ayes appear to have it. The ayes do have it, and the meeting is adjourned.